سلام به همه. من خلاصه عقلم رسید که این ایپاب رو تبدیل به PDF کنم برای این کتاب و با هم بخونیم. فصل 5 شد. Medical shows on TV are popular because we are enraptured by the brilliant doctor who plucks an esoteric diagnosis out of the hat based on some obscure clinical details and a keen memory for arcane facts. When we ourselves are patient, however, we prefer decidedly less drama. We like it when the diagnosis is straightforward and reassuringly boring. In real life, nobody wants to be a diagnostic puzzle or a cliffhanger ending. As you can see with Jay, real life in medicine is immensely complicated. Textbook logic for making a diagnosis falls apart in the messy world of human physiology, rendering medicine even less akin to the aviation industry. Even when we think we have a culprit in Jay's case, the MRSA bacteria growing in his blood, there is still uncertainty. Jay's condition was worsening despite antibiotics for MRSA. Was the problem ineffective treatment, delayed treatment perhaps? There were other diagnoses brewing alongside the MRSA infection. It was particularly notable that Jay was short of breath and remained febrile. Shortness of breath has many possible explanations, but in the presence of a fever, pneumonia is the prime contender. His chest X-ray was reported as negative for pneumonia, but this illustrates one of the challenges of making an accurate diagnosis. Does a negative chest X-ray mean that the patient does not have pneumonia? As always, context counts. A negative chest X-ray could reasonably rule out a pneumonia in a healthy person with a mild cough sitting comfortably in a doctor's office. But in the context of a critically ill, febrile, immunocompromised patient in a hospital ward who is struggling to breathe, a negative chest X-ray assumes a different meaning or several meanings. It could represent a false negative, that is, the pneumonia exists but the X-ray didn't show it, or a negative X-ray report could mean that the radiologist made an error when reading the film, but the X-ray actually did show a pneumonia. Alternatively, it could be that an X-ray is the wrong test to diagnose pneumonia. In this context, an X-ray might simply be incapable of picking up a pneumonia in a patient whose devastated immune system can't gene up the normal inflammatory response that creates the typical X-ray findings. Patients often assume that tests such as X-ray are objective, like calculators, but put in the numbers and the correct answer will be spit out. Reading X-ray, however, is learned cognitive skill done by humans who have to render subjective decisions about what constitutes normal and what constitutes pathology. Sometimes a pneumonia on a chest X-ray is blindingly obvious. An entire chunk of lung is whited out from inflammation, but often the radiologic signs of pneumonia are subtle. Countless times I've stared a patch of haziness on an X-ray until my eyes water, debating whether this vague fuzziness represents a true pneumonia or whether it's just a schmutz, a word that has migrated seamlessly from Yiddish to official radiologic terminology. A good radiologist spends years staring at films, learning the copious variations that inflammation and infection of a lung tissue can take. Because X-ray reading is essentially about visual pattern recognition, it's an area in which technology and artificial intelligence is making headway. You teach a doctor to read X-ray by showing her enough examples during her training, and the idea is that you could similarly teach a computer system the same thing by inputting a sufficient number of images. Trial and error should allow the system to learn to distinguish what is pathology from what is schmutz. A group of researchers from California have tried to create such a system by uploading images from 120,120 chest X-rays. These X-rays have been individually labeled as normal or as having up to 14 abnormalities, including pneumonia. The researchers created an algorithm to analyze the images and, with machine learning, were able to train the system in much the way you would train a radiology resident. They then tested the system within 420 new X-rays to see how well it did in diagnosing pneumonia, and for fun, they tested it against 9 radiologists from esteemed academic institution who independently reviewed the same 420 images. The computerized system did just as well as its human counterparts for 10 of the 14 pulmonary abnormalities, including pneumonia, lung masses, and fluid in and around the lungs. The radiologist edged out the system for emphysema, hiatal hernia, and enlarged heart. Furthermore, it was able to evaluate the 420 X-ray in 1.5 minutes, whereas the human took an average of 240 minutes. It isn't necessarily surprising that the computerized system did so well and didn't need coffee or bathroom breaks, since accurate pattern recognition relates to the sheer amount of experience in seeing prior patterns. With a computerized system, you can take the foie gras approach and endlessly cram in the images. Unlike with a goose or a radiology resident for the matter, you won't get the squawks, ruptured intestines, or oh, it's 6 p.m. I gotta run. Success with visual pattern recognition has sparked interest in using artificial intelligence and computerized algorithms to improve diagnostic accuracy for a wide variety of medical conditions. For a straightforward clinical situation such as whether an ankle injury requires an X-ray to distinguish a sprain from a fracture, it's relatively easy to create an algorithm, but it's a whole other can of worms to teach a computer to make a diagnosis when a patient presents with a vague symptom like my stomach hurts or I'm feeling more tired these days. Improving the grand diagnostic process is sometimes of a holy grail for researchers in the field. Wouldn't it be great to have a system in which you could enter the patient's symptoms and the program would create an accurate differential diagnosis? It would include all the rare diseases, but fallible humans tend to forget, but of course eliminate the ones that are too far out in left the field. It would generate an intelligent roadmap for a thorough but not reckless workup. It would take into account cost efficiency and clinical context and assiduously avoid both false positive and false negative errors. Holy grail indeed. Some diagnostic tools have been created with this goal in mind, and a few of them are out there in practice. Isabel, Visual DX, and DXplain. This is medical shorthand for diagnosis. A review that analyzed all the published studies about this program came to mixed conclusions. Researchers didn't find compelling evidence to make a wholesale recommendation for doctors to use this, but did say that they had the potential to be of assistance. I spent an afternoon trying out these systems when I was supervising in our walk-in clinic. Each time a resident or student presented a case, I would enter the symptoms into the system before I pressed submit. We had come up with our own differential diagnosis and then compare our result to the computer. For the cases that were straightforward, the system was far too laborious. Our minds were much faster and more efficient. But then we got a case that represented a diagnostic dilemma perfect for testing out the system. The case involved a young, healthy woman in her early 20s who has experiencing episodes of rapid heart rate and shortness of breath. She had previously played on sport teams but was now too fatigued to do so. Financial difficulties has recently forced her family to move into a cramped basement apartment. She disliked it intensely and felt very anxious whether she was alone in the apartment. She had already stayed overnight in the hospital after an ER visit, and the major cardiac causes has been ruled out. The cardiologist felt it was anxiety that was making her heart race, and when they gave her a beta blocker to slow the heart rate, she felt better, though not completely. As soon as my team and I began typing in the symptoms, we realized just how formidable it is to quantify the diagnostic process. Entering tachycardia and dyspnea, racing heart, and shortness of breath brought up a voluminous list of possible diagnoses. The system was casting a wide net so that it wouldn't miss anything, but we humans wouldn't have wasted an iota of mental effort on a good chunk of their diagnosis. For example, the list was headed up by septic shock, which of course can present with those symptoms, but when you are evaluating a healthy appearing woman who is smiling and chatting amiably with you, septic shock would never enter your mind, as opposed to when you are evaluating a patient like Jay, who also had tachycardia and dyspnea. Nor would massive hemorrhage or ruptured aortic aneurysm, two other diagnoses that appeared on the list. There was no box to type in the gist of what this young woman was like. There was no place for context, there was no fit to inter psychosocial issues like financial stress forcing move to claustrophobic a subterranean apartment. I don't fault the system for this, but these limitations highlight the breadth of the elements that enter into the diagnostic process. Furthermore, the system would not be able to consider that a basement apartment might host more mold than an upstairs apartment. Mold causes or exacerbates a host of pulmonary ailments from asthma to aspergillosis to hypersensitivity pneumonitis, so the system would miss these possibilities. In reviewing the differential diagnosis list that the system provided for our case, we quickly crossed off the assorted catastrophic conditions that weren't remotely a consideration in a walking, talking, not prostrate on a gurney patient. The remainder of the list mostly contaminated things we had already considered, such as hyperthyroidism and anemia. It didn't mention a few that we might not have thought about, such as acute porphyria and sodium azide poisoning. It did mention a few. Sodium azide poisoning. Our conclusion was that the system didn't really parallel the manner in which we think about patients, but it could be useful to jog our memories for rarer things. One of the major criticisms of these computerized diagnosis system is that they have an incentive to cast their nets as widely as possible. This allows the commercial developers to tout impressive statistics about how frequently the correct diagnosis appears on the list, but in actual clinical practice, doctors have to make real-world trade-offs, especially when it comes to rare diagnoses that require expensive tests with risk to harm the patient. We also have to factor in the logistics of the diagnostic workup. How long will it take to get a CT scan? Does the patient's insurance cover an MRI? When is the next available rheumatology appointment? Can the patient take off time from work to get that thyroid scan? There are also patient's preferences that affect the diagnostic process. How aggressive does he want to be? How risk averse is she? What are his financial concerns? All of these real world considerations play a role in how we do diagnostic workups, all intricacies that do not burden these sleekly inconscient algorithms. Lastly, there are the practical aspects of real-time use. These systems take time to employ. A doctor would have to, in essence, stop her evaluation for the patient in order to give time to the algorithm. Given how time-crunched medical evaluations are these days, anything that subtracts from the already limited direct face time between doctor and patient has to offer proven value. The systems are impressive works of technology whose role is still evolving. Most likely, there will be resources for complex cases and for teaching, but it's important to keep in mind that simply generating a list of possibilities isn't the same as making the diagnosis. A computer doesn't have to commit, a doctor does, and so does the patient. For the young woman we were evaluating in the walk-in clinic, most of the workup came back negative. Her chest X-ray and pulmonary function tests were normal. Unlike a computerized algorithm, we still had to do something to help her symptoms. We still had to commit even in the absence of a specific diagnosis. The most important diagnostic clue remained the fact that her breathing was better when she was out of the apartment. So whether it was mold in the apartment that was triggering respiratory symptom or claustrophobia that was causing anxiety, the best treatment we could offer was to help her structure her life to spend more time away from the apartment. She began spending weekends with her aunt and occasional weeknights with friends. On a follow-up visit, she said she felt that her symptoms were improving. She was now focusing her energies on saving enough money to eventually move out on her own. Computerized algorithms are only way to try to minimize diagnostic errors, but is there a way to improve how doctors do their own internal algorithms? Is there a way to improve the actual thinking? Refining this overall process of diagnostic reasoning is a more global approach that could potentially improve things in all areas of medicine, and it would avoid the pitfalls of the disease of the week approach that many healthcare systems use in tackling medical errors. Mark Graber and Hardipsine, the researchers focused on improving diagnostic accuracy, admit that targeting things is far more challenging than standard quality improvement projects such as reducing hospital-acquired infection or screening for depression. Is it an impossible task? With 10,000 diseases, there is so much uncertainty, Graber admits. We get it right 90% of the time. That's pretty amazing. And then he adds slyly, but can we get it to 95%? Nudging the accuracy rate up rather than attempting to eliminate all diagnostic errors seems like a double prospect. But thinking styles are deeply ingrained and decidedly recalcitrant when commanded to evolve. Our declaration of rationality are routinely undercut by our unconscious biases, not to mention those rascal emotions that we are convinced we retain mystery of. Additionally, our thinking styles are routinely and unceremoniously jolted when we are rushed, pressured, inattentive, or otherwise distracted. There are times when we cogitate like Kant, and other times when we rely on intuition and guesswork like $5 sidewalk psychics. Mental shortcuts abound in our reasoning, and our reliance on them is matched only by our cheaper unawareness of using them. Such capricious thinking patterns aren't as amenable to typical patient safety checklists or aviation style standardization. Furthermore, it's not clear how much research could even be done as Semmelweis, Nightingale, and Pronovost all demonstrated. You need to be able to measure the problem, apply an intervention, and then track the results with meaningful real-world outcomes. How would you think even the first step with regard to diagnostic reasoning? There isn't a thoughtmeter that researchers can seamlessly slip into our cerebral gyre to measure our reasoning process in all its feats of brilliance and banality. If asked, most of us probably couldn't even describe how we think. So while it makes intuitive sense to work on the thinking process, doing the actual research is no picnic. As a result, data in this field are notably sparse. Nevertheless, since the thought process is the source of most diagnostic error, there is still value in pursuing this avenue. It's especially beneficial in the early years of medical school and nursing school, as this is when diagnostic habits are formed, and even for established clinicians, there's probably at least some value in thinking about how we think. Even if only modestly effective, it's likely the truest way to decrease diagnostic error. There are several techniques that can be used to hone our diagnostic thinking process, and they share in common the idea of resisting the urge to jump to an easy conclusion. They start with Graeber's dictum about the discipline of the differential diagnosis. Every time doctors evaluate patients, they should force themselves to consider a range of possibilities before homing in on a single one. The very act of considering alternatives opens up the mind to, well, alternatives. You can't get to a particular diagnosis if you never actually consider it. So how do you do this in real time? As soon as the first diagnosis is entertained, the doctor and the patient should ask, could it be anything else? Graeber and Say call the universal antidote to diagnostic error, and then keep asking it. A cough, for example, may seem like a standard viral upper respiratory infection at first blush, but what else could it be? Sinusitis, bronchitis, influenza, and pneumonia all have a cough component. Gastric reflux can present with a cough, as can asthma. A cough could also be a sign of congestive heart failure or a side effect of ACE inhibitors, a class of blood pressure medication. The cough could signify tuberculosis or lung cancer. It might be emphysema or pertussis. A cough could be caused by environmental irritants such as mold, or by accidentally inhaling objects that are best left outside the body. What else could it be? Well, there are a host of less common conditions that can present with cough, such as sarcoidosis, interstitial lung disease, vascular malformation, or blood clots in the lung. And then there are the rare diseases such as amyloidosis, relapsing polychondritis, granulomatosis, polyangiitis, and psychogenic cough, and the even rarer conditions like synghamosis, pulmonary Langerhans cell histiocytosis, and tracheobronchopathia osteochondroplastica. Or maybe the cough is just plain old postnasal bleed. While it isn't necessary to hoof it as far as tracheobronchopathia osteochondroplastica for the average patient with a cough, the point is that the more you ask yourself what else could it be, the more ideas you come up with. The vast majority of coughs will fall into the first few tiers of the differential, but it's still important to think beyond, as attendings intone ad infinitum to medical students on rounds. No one ever made the diagnosis of sarcoidosis without first considering sarcoidosis in the differential. The nice thing about the what else could it be strategy is that it's straightforward and its logic fits naturally with the whole idea of the differential diagnosis. There are some variations on the strategy considering the consequences of a misdiagnosis of a more severe illness is another way to challenge your thinking. Yes, most coughs in a typical primary care setting flower in the URI, bronchitis, sinusitis garden and will get better on their own no matter what you do or don't do. But what if the cough is the harbinger of a lung cancer or a blood clot? Missing these could be devastating, even deadly. So even though they are far less frequent, we always need to be sure we have thought about these severe diagnoses and then rallied the data that would exclude them. When I am reviewing a case with students or interns, I push them to give a full differential, not just jump out with the one diagnosis that seems obvious. After they have provided their list, I'll ask the two golden questions: what else could it be, and is there anything that we can't afford to miss? The hard part is remembering to do this for myself when I'm rushing through a busy day, backlogged with patient and overwhelmed with the never-ending EMR and minutiae. This discipline melts away faster than the smooth talk from a drug rep. If it walks like a upper respiratory infection and quacks like upper respiratory infection, I'll pretty quickly chalk up that cough to a upper respiratory infection without rigorously questioning myself. How many diagnostic errors have I made by doing this? Unfortunately, I'll never know. Another cognitive trick is to focus on the data that don't fit your presumptive diagnosis. If I'm making the diagnosis of upper respiratory infection in a patient with a cough who also has a rash, I should expand a neuron or two on the fact that rash isn't usually associated with the upper respiratory infection. That would force me to reconsider my diagnosis. Maybe it's something other than upper respiratory infection, such as infection with parvovirus B19 or EBV, or maybe the patient has two different things going on. Patients with upper respiratory infection, after all, are allowed to also have eczema, or maybe the patient took a medication to treat the upper respiratory infection and had an allergic reaction to it. The question and exercises designed to sharpen diagnostic thinking have the making of, you guessed it, a checklist. Mark Grapper, along with John Ellie and Pat Croskery, explored the idea of checklists for diagnosis and recognized that you really need two distinct types of checklists, one for content and one for process. Content checklist could be the computerized algorithms mentioned earlier that are tailored to the specific patient data that you enter, or they could just be plain old lists. Ellie, a family physician in Iowa, developed a convenient set of lists for outpatient use. He categorized the 46 most common complaints in outpatient medicine: dizziness, abdominal or pelvic pain, diarrhea, headache, insomnia, etc., and then listed a dozen or two of the most common causes, with a few tricky ones labeled commonly missed and a few serious ones labeled do not miss. It's a quick way for a doctor to run down a list and make sure she hasn't missed anything. By contrast, process checklists review the thought process, looking for biases and shortcuts that might undercut diagnostic accuracy. Grapper, Tsai, and colleagues created a process checklist that include the standard, what else could it be, and what can I not afford to miss, but also ask more other interesting questions that can affect accuracy. Did I simplify? Did I simply accept the first diagnosis that came to mind? Did someone else, patient, colleague, already put on a diagnostic label that's biasing me? Was the patient recently evaluated for the same complaint? Am I distracted or overtired right now? Is there a patient that I don't like for some reason? Is this a patient I like too much? Family member, friend, colleague? The point of this question is to make you stop and think. For complex cases in which things don't make sense, you can take the extra step and do a full-fledged diagnostic timeout similar to the standard timeout procedure before starting surgery. This is especially helpful when existing diagnoses don't quite add up. I have a patient whose chart listed rheumatoid arthritis in every note since the Paleolithic era. When I took over her care from a departing doctor, I dutifully listed RA in every one of my notes over the years, though it slowly dawned on me that she never actually experienced any specific symptoms of RA, such as swallow and tender joints in a symmetrical distribution associated with significant morning stiffness. One day I finally took a diagnostic timeout and dug back through her voluminous chart. After some deep hunting, I found a workup from years earlier in which two classic blood tests for RA were positive. That, alongside some non-specific aches and pains, was how the diagnosis was implanted in her chart. It became entrenched, and every subsequent doctor repeated the gospel until it was simply a fact of her medical history. But the truth was that she didn't actually have rheumatoid arthritis. Those initial blood tests were likely false positive. Diagnoses do indeed evolve over time. This one took a decade to figure out. Diagnostic checklists, however, are harder to implement than other checklists. Pre-surgical checklists consist mostly of clear-cut, tangible items. Did we check the patient's name, the surgical site, They take 1 second to answer, and then you are done and can move on. Well, how do you know when a thought is done? How do you know when to end the what else could it be line of thinking? How do you decide whether your fatigue or distraction are significant enough to impair your thinking, given that everyone is exhausted and that interruptions are innocent? Additionally, most pre-surgical and pre-flight checklists are performed loud with other people not so in diagnosis. Diagnosis is usually silent, lonely work. Right early grabber and cross carry a natural pause point to review the checklist, such as before takeoff or before incision, doesn't exist in diagnoses, which can stretch over hours, days, or even months. Many doctors find diagnostic checklists off-putting because they include things that are obvious, even insulting. Take a complete history, read the X-ray yourself, take time to reflect, but these authors point out that pilots don't feel insulted running down their checklist or being questioned by their co-pilots. They might have initially, but now it's simply part of the job. Importantly, they don't do it only in difficult situations. They do it every time, even when they are flying with the most experienced crews on the most perfect sunny days. Doctors, on the other hand, tend to see value in this checklist, if they do at all, only for the difficult cases and diagnostic conundrums. When I think honestly about my own practice style as a physician, I recognize with no small amount of abashment that my approach is cursory, or intuitive far more than I would want to admit. In the survival mode that most doctors and nurses work in today, it's easy to fall back on a snap judgment and obvious diagnosis. Fighting the current to slow down and question my thinking is arduous, especially when I feel like I'm struggling just to keep my head above the water most days. On Monday morning, a patient handed me a note from a pain management doctor that he was seeing at another institution. In the course of sending out an unnecessarily expensive panel of blood tests, the cortisol level came out slightly low. The doctor had jotted a one-liner for me on a sheet of his prescription paper, ruled out adrenal insufficiency. As my patient began updating me on his 6 other chronic conditions, I surreptitiously pulled up the web page on adrenal insufficiency. Not that I don't remember every detail of adrenal vagaries, mind you, and sure I would re-memorize it all for my broad recertification 2 years prior. But let's just say that adrenal insufficiency is one of those conditions that resides out on a wobbly, far-flaunting cortical gyrus. one از adrenal insufficiency. پدر آدم در میاره. Adrenal insufficiency is a notoriously knotty topic. The symptoms are both varied and vague. There is primary adrenal insufficiency and secondary adrenal insufficiency. There is acute adrenal insufficiency and chronic adrenal insufficiency. To test for it, I would have to give the patient a dose of a hormone to stimulate the adrenal gland and then check cortisol level at 0, 30, and 60 minutes. There were at least 10 variations on how to administer that hormone and even more variations on how to interpret the results. And could I even figure out how to order 3 separate time blood draws? Within a minute, my head was spinning. While my patient updated me on his back pain, his diabetes, and his GI symptoms, I dug through the fine print to remind myself which way the diurnal variation of cortisol runs, up in the morning, down at night, or vice versa. My patient stacked his 15 medication on my desk, all of which needed refills and all of which could interfere with the adrenal function and adrenal testing. I realized I simply couldn't sort this all out in the moment. What I needed was time to think. I found myself pining for those medical school Saturdays in the library, endless hours to read and think, nothing but me, knowledge and silence facing off in a Tai Chi battle of concentration. How I hated those study sessions then, and how I would have given my left adrenal for a few minutes of that now. But a gazillion EMR fields were demanding attention. 3 more charts were waiting in my box. The patient still had 2 MRI reports and an endoscopy report for me to review, plus a question about prostate testing. His adrenal insufficiency was swamped by my cerebral insufficiency. I could tell him I would review his case later and get back to him, but what later? Were we talking about my morning session would run overtime by hours? That was a given. There were last week's labs to review, students' note to check, patients' calls to return, meds to renew, forms and papers erupting in a copyist dystopia all over my desk. There would never be any later. Later is the fantasy dreamed up by a bureaucrat who have never set foot outside the cubicle. There was only now. But if I made any clinical decision now, they would be a haphazard, rife with potential for error. They would be an embarrassment. I finally threw in the towel and scribbled a referral to endocrinology. Let them deal with it. I hustled my patient out the door and hurried the next person in. In the pressurized world of contemporary medicine, there's simply no time to think. It certainly doesn't feel like I have time to run through extensive diagnostic checklists, no matter how logical and important they seem. I sometimes feel as though I'm racing to cover the bare minimum, sprinting in substance level intellectual mode, because that's all that's sustainable. I confess that I harbor a fear of anything atypical popping up during a visit. I dread symptoms that don't add up, test results that are contradictory, patients who lodge in bagfuls of herbal supplements with instructions to ask your doctor. If I can't spring to a conclusion in a minute flat, I'm sunk. God help me if their medical history includes Sturge-Weber syndrome or polyarthritis nodosa. I don't even have enough time to type them or spell them, much less look them up and remind myself what they are. So when I think about the reasoned approach that Graberstein and other researchers suggest, I applaud it, I second it, I yearn for it, but it's hard to see how it can fit in with the everyday experiences of most doctors and nurses. A few days after the visit with the patient, I happened on Core IM, an internal medicine podcast created by some of my New York University colleagues. One of the hosts mentioned an episode on adrenal insufficiency is one of those topics he observed that's never nailed down fully. Oh, so maybe I wasn't the only idiot who couldn't iron out adrenal insufficiency on the fly. Maybe I wasn't such a loser for not being able to orient the hypothalamic pituitary adrenal axis in the middle of a chaotic clinic session. I listened to the episode and then read the chapter with an actual case in hand. The physiology clicked more easily. The next day I went to work early, opened the patient chart and received through his data. I still wanted him to see an endocrinologist, but at least now I didn't feel like I was handing off a mess. I appended my initial note with a more intelligible analysis and called the patient to explain our plan. When I closed out the chart, I felt satisfied with the case. For the first time in retrospect, I realized that I had taken a full-fledged diagnostic timeout, which is what this case required. It felt frankly thrilling to have given medical care at the appropriate level of thoroughness, to have fended off the cuttings of corners we are so often forced to employ. Of course, sorting out this one issue for this one patient took a full hour outside his visit. I couldn't have pulled it off in the moment, and I couldn't carve out an extra hour during the non-existent later for every patient with a complex problem. But that's what so many of our patient diagnoses require: time to think, consider, revisit, reanalyze. From the billing and coding perspective, this is supremely inefficient. There is no diagnosis code for cognitive pandemonium. There is no billing code for contemplation, but extra time dedicated to thinking, using diagnostic checklists to expand our differential diagnosis as well as to examine our thinking process could actually be remarkably efficient. Time to think seems quiescent in our metrics-driven, pay-for-performance, throughput-obsessed healthcare system, but we have made fewer diagnostic errors and surely save money by reducing unnecessary tests and cop-out referrals. I suspect time to think would also make a substantial dent in the demoralization of medical professionals today, but that's a whole other story. خب چون خیلی داره طولانی میشه من این فایل رو اینجا قطع میکنم. امیدوارم که تا اینجاش براتون خوب باشه، بعدا ادامهش میدم.